All right, welcome back to the deep dive. Today we're jumping into a world that's pretty much everywhere, but often, completely overlooked.
We are. We're talking about the fungal kingdom.
And not just, mold on your bread or something simple.
No, not at all. We're going way beyond that. We're talking about mycosis fungal infections. And what we've put together for you
Yeah.
is a really comprehensive sort of clinical roadmap. It's all based on some pretty advanced medical and pharmacology notes.
That's right. I think for most people, when you say fungus, they immediately think of something like, I don't know, athlete's foot, a skin irritation. But what our sources make incredibly clear is that this world is, well, it's vast, it's complex, and it includes some really life-threatening systemic diseases that are, frankly, becoming more and more relevant in modern medicine.
They are. So our mission today is to really give you that full picture. We want to cover how fungi are classified, why some of them are just, superficial nuisances, and why others are true systemic threats.
And then we get to the really good part.
The pharmacology. We're going to dissect how modern medicine actually fights back. We'll give you a detailed breakdown of the strategies, the polyenes, the azoles, the whole toolkit.
And we're going deep on this. We're talking specific molecular mechanisms of action, dosing particulars, the stuff that really matters in a clinical setting.
Exactly.
So you'll walk away not just knowing what a fungus is, but really understanding the sophisticated biochemical warfare that's waged against it.
We'll start at the fundamentals, the basic biology, then move through the common skin infections that affect so many people, and then finish up with that deep dive into the treatments.
Okay, let's do it. Let's unpack this huge kingdom. Where do we start?
Well, the sources point to a really fundamental breakdown first, and it's based on morphology.
Morphology. So what they look like, how they're structured.
Precisely. And the two big groups are yeasts versus molds.
Right.
And this distinction is, it's critical because it really dictates how the organism grows, how it spreads, and often its potential to cause serious disease.
So let's start with yeasts. What defines a yeast?
Yeasts are the unicellular fungi.
Single cells. That's it.
Exactly. Just single cells. In a lab culture, they typically look, white. And their main way of replicating is through budding.
Budding. So they just sort of pinch off a copy of themselves.
That's a great way to put it. A little daughter cell pinches off from the parent. And the two key players here, the ones that cause the most significant human disease, are Candida albicans and Cryptococcus.
Okay, but the sources add a little nuance here because even though we call them unicellular, they don't always stay as these perfect, single, isolated spheres.
That's true, and that organizational ability really speaks to their flexibility as pathogens.
So they can change their shape.
Under certain conditions, yeah. Especially when they're invading tissue, some yeast species can actually organize themselves into these long, chain-like structures. They're called hyphae, or more accurately for yeasts, pseudohyphae.
False hyphae.
Right. And these chains allow them to penetrate deeper into tissues.
That structural change must be just absolutely key to how they cause disease.
It is. It's a major virulence factor.
Okay, so that's yeasts. Now, what about molds?
Molds are, well, they're the complete opposite. They are multicellular.
All right, the fuzzy stuff.
The fuzzy stuff, exactly. They organize themselves into these long filaments called hyphae, and those hyphae form complex networks that, we see as mold growth. And they come in a huge variety of colors, black, green, red.
And their reproduction is totally different from budding.
Totally different. They rely mainly on spore formation. They produce these tiny, lightweight spores that are often just floating in the air, basically waiting for the right opportunity to land and grow.
And the clinically important examples here.
The big ones we need to worry about are Aspergillus and Histoplasma.
Okay, so this brings us to a really important conceptual split that our sources lay out. The difference between what they call the commensal threat and the environmental threat.
This is where we connect the biology directly to clinical practice. Let's look at the yeasts first, specifically Candida albicans. What's so fascinating about Candida is that it's the single most clinically relevant fungal genus. And that's because it's a commensal organism.
Commensal, meaning it's supposed to be there. It's a normal resident.
Exactly. It's part of your normal flora. It lives in your oropharynx, your mouth and throat, your GI tract, and the vagina. It's just there.
So if it's supposed to be there, when does it become a problem? What flips the switch?
It only becomes a problem when the host's internal ecosystem gets disrupted. It causes what we call opportunistic infections, or OIs.
Okay, and that happens in a couple of scenarios.
There are two main scenarios. First, and most obviously, when the person becomes immunocompromised.
Chemotherapy, HIV, high-dose steroids, that kind of thing.
Right. The immune system can't keep it in check anymore, and the yeast just proliferates uncontrollably and starts to invade tissues.
And the second scenario?
The second one is when the normal bacterial flora is severely disrupted. This happens all the time with the use of broad-spectrum antibiotics.
Ah, right. This is incredibly common. The antibiotic you're taking for, say, a bacterial infection, it kills the bad bacteria, but it also wipes out all the protective good bacteria.
And that leaves a vacant ecological niche. Candida, being highly adaptable, just seizes that opportunity and overgrows. We call that a superinfection.
And that explains why things like oral thrush or a vaginal yeast infection are such common side effects after a strong course of antibiotics.
It's the classic example.
Okay, so that's the commensal threat from within. Now let's contrast that with the environmental molds.
The molds are a completely different story. They're incredibly diverse, and the vast, vast majority of them are non-pathologic. They just break down dead stuff in the environment.
But our sources highlight two major groups that are definitely pathogenic.
They do. Genus Aspergillus and the order Mucorales.
Mucorales.
Yeah.
That includes things like mucor and rhizotapus.
Yes, Mucor, Rhizopus, Rhizomucor. And these are truly environmental pathogens. They aren't sitting in our gut waiting for their chance. They're purely external.
So you find them out in the world.
All over the world. The molds themselves and their spores are found in soil, in dust, in decaying vegetation. They're everywhere. And they get into the body through inhalation of those airborne spores.
And once someone breathes them in, what's the typical target?
They are notorious for causing rhinosinusitis, so a really nasty infection of the nose and sinuses, and various severe pulmonary infections like invasive aspergillosis.
And here's the crucial clinical point, right? These infections don't just happen to anyone.
Almost exclusively, no. They occur in profoundly immunocompromised patients. They aren't waiting in your body. They're waiting in the environment for an immune system that is weak enough to not fight back the moment they're inhaled.
Okay, so that's a great transition from what they look like to where they attack, the clinical classification.
Right. And we can basically put them into two huge buckets, superficial and systemic.
Superficial is the common stuff, the things most healthy people might actually run into.
Exactly. These affect the skin, which is cutaneous, mucous membrane, so mucocutaneous, and then hair and nails.
And the general term for these is dermatophytoses.
Dermatophytoses, and this includes things we've already mentioned, vulvovaginal candidiasis, oral thrush, and just general skin, hair, and nail mycotic infections.
So they're irritating, they can be recurrent, sometimes painful, but they are. They're almost never life-threatening in an otherwise healthy person.
That's the key. The real clinical threat, the reason we have drugs like amphotericin B, is systemic mycoses.
These are the deep-seated diseases.
The ones that affect the internal organs. And the sources are very clear that the respiratory tract is the most common primary portal of entry.
Which makes perfect sense given what you just said about inhaling environmental spores like Aspergillus.
Exactly.
And we can break down that systemic group even further.
We can, into opportunistic and non-opportunistic. And that distinction all depends on the host's baseline immune status.
So which ones fall into that opportunistic group? The ones that need a weakened host?
These are the infections that essentially need permission to get started. They require a compromised host defense to really establish themselves. This includes candidiasis, but when it goes systemic, beyond the superficial layer.
Okay.
And then cryptococcosis, aspergillosis, and mucormycosis. These are the infections that they trigger a very high level of concern in ICUs and oncology wards.
And what about the non-opportunistic systemic one listed in the notes?
That would be histoplasmosis. It's often contracted from exposure to large amounts of bird or bat droppings, which carry the spores.
And this one can infect healthy people.
It can. It can cause a systemic infection even in people with seemingly normal immune systems. Although, as you'd expect, the severity and progression are significantly worse if there's any underlying immune compromise.
Okay, so let's drill down into that vulnerability. Who exactly is in that high-risk category? This is so important for connecting the dots, understanding what specific factors turn a harmless exposure into a systemic crisis.
We really have to be meticulous here, because these risk factors define the patient population. The primary group is, of course, the immunosuppressed patient. But that's a huge umbrella.
Right, so let's get into the specifics from the sources.
Okay, first, patients with hematologic malignancies, so cancers of the blood, like leukemia.
Why them specifically?
Because the intense chemotherapy they receive often leaves them profoundly neutropenic,
Neutropenic, meaning they have very low levels of neutrophils, a type of white blood cell.
Exactly. The neutrophils are the body's first responders. They're the frontline soldiers. And when they're wiped out by chemo, there's nothing left to fight off an inhaled mold spore or an overgrowing yeast.
So modern chemotherapy, while it's life-saving for the cancer, it basically creates this perfect defense-free environment for opportunistic fungi. It's an unavoidable trade-off.
It is a very dangerous one.
Mm.
Other conditions that impair cellular immunity are also critical. Diabetes is a major risk factor,
Especially for mucormycosis, right?
especially for mucormycosis, which seems to thrive in high glucose acidic environments, like those seen in diabetic ketoacidosis.
Diabetes is so widespread, I don't think most people appreciate just how much it can compromise the immune system's effectiveness.
They really don't. And then we have the pharmaceutical risk factors. The use of certain medications just skyrockets the risk.
Like what?
High-dose corticosteroids, they suppress the entire immune response to reduce inflammation. Also, other immunosuppressants used for autoimmune diseases or for organ transplant recipients.
Of course. If you're deliberately dampening the body's defenses to prevent organ rejection or self-attack, it can't tell the difference between a fungal spore and anything else it's supposed to ignore.
It can't. And finally, the factor we mentioned before, the use of broad-spectrum antimicrobial agents.
The antibiotics that destroy the protective bacterial flora.
Right. It destroys that barrier and that ecological balance, and it allows Candida to switch from being a harmless guest to being an aggressive invader.
You know, this context really crystallizes why systemic fungal infections are, in many ways, a disease of modern medicine.
How do you mean?
Well, we're incredibly good now at extending life through cancer treatments, organ transplants, managing chronic conditions. But in doing so, we've inadvertently opened up this critical niche for these highly opportunistic pathogens to exploit. The balance is it's incredibly delicate.
It's a huge clinical challenge because you can't stop treating the cancer. You can't stop the immunosuppressants in a transplant patient. So the risk of a fungal infection just becomes an integral part of that patient's ongoing care plan.
And this really sets the stage for why the pharmacology, which we'll get to, has to be so aggressive and so precise.
Exactly.
All right, let's step back from the life-threatening systemic issues for a moment and focus on the common but incredibly persistent everyday problems, the superficial mycoses.
We're talking about dermatophytoses, the family of infections that includes, ringworm, athlete's foot, jock itch, nail
The
infections.
stuff that's annoying but not usually deadly.
Annoying is a good word for it. These infections are caused by a specific group of fungi called dermatophytes, and they have this specialized ability to consume keratinized tissues.
Keratin. So the protein that makes up the outermost layers of our skin, our hair, and our nails.
They literally feed on the structural proteins of our appendages.
Our sources break down the three main genera responsible for these. So let's identify that trio and where they specialize.
Okay, the three major genera are trichophyton, microsporum, and epidermophyton.
And the distinction between them is where they like to attack.
Exactly. And it's clinically relevant. Trichophyte is the most aggressive and versatile. It can infect the skin, the hair, and the nails. We call it the triple threat.
A true generalist of keratin consumption.
Indeed. Then you have microsporum. It's happy with the skin and the hair, but the sources say it doesn't typically infect the nails.
Okay.
And finally, epidermophyton. It specializes in the skin and nails, but it leaves the hair alone.
And knowing which one is at play can help guide the treatment.
It can, especially when you're dealing with those really stubborn, deep-seated infections of the hair and nails.
And generally, what are people experiencing? The symptoms are pretty classic, right?
They are. You see redness, irritation, scaly skin, intense itching, swelling, and sometimes even blisters. It's the body's immune system reacting to the fungus feeding on the keratin.
All right, let's get specific with the clinical vocabulary, starting with the one everyone knows, tinea pedis. Athlete's foot.
The scourge of locker rooms, yes. Tinea pedis is incredibly widespread, and it usually presents in one of three ways.
Okay, what is the first one?
First is the interdigital type. This is characterized by macerated, soft, wet-looking skin, typically between the fourth and fifth toes. It's often the mildest form.
Then there's the one I always found interesting, the moccasin type.
Yes, this is very distinct. It's dry, thickened, scaling skin that covers the entire bottom surface and the sides of the foot. It looks like the foot has been dipped in a flaky powder up to the ankle, like it's wearing an invisible moccasin.
And the third type.
The vesiculobulous type. This presents as itchy blisters or vesicles and bulla, usually on the arch or the bottom of the foot. It often signals a more inflammatory reaction from the body.
We always hear about locker rooms, but what are the specific transmission routes that maybe people don't think about as much?
Well, the initial transmission is straightforward walking barefoot in communal damp areas, but the propagation, the self-reinfection, that's key.
What do you mean?
It's often perpetuated by repetitive use of soiled or wet footwear, and, crucially, a fungal infection in the toenails can act as a persistent reservoir, constantly reseeding the surrounding skin with tinea pedis.
So if you don't treat the nails, the foot infection will just keep coming back.
Exactly. And of course, you can spread it through shared items, clippers, socks, shoes, and this is where the actionable knowledge comes in. If you want to prevent this, simple changes make a huge difference.
Okay, give us the top 3 preventative measures from the sources.
1. Meticulous drying. Keep your feet clean and critically dry,
Yeah.
especially dabbing dry between the toes instead of rubbing. 2. Socks. Wear socks made of natural fibers like wool or cotton and change them daily or as soon as they get wet. 3. Wear protective footwear. Flip-flops, shower sandals, whatever, in communal areas. And a final point for anyone with diabetes, managing that underlying condition is critical for maintaining skin integrity.
And what about treatment? For mild cases, it seems like topical therapy for a few weeks is usually enough.
It often is, yes, 2 to 4 weeks. Topical agents like clotrimazole or terbinafine creams work by concentrating the drug right at the site of infection. But
That's it.
if the infection is extensive or very inflammatory or involves the nails, you have to use oral therapy. And this move to systemic drugs is crucial because the recurrence rates for tinea pedis are incredibly high. The sources cite up to 70%.
70%, wow.
Yeah, often because of reservoirs like contaminated shoes or those chronically infected nails we just talked about.
So what are the oral options for a more aggressive case?
The main ones are terbinafine, usually for 2 weeks, itraconazole, which can sometimes be dosed for just 1 week, or fluconazole, dosed once weekly for 2 to 6 weeks.
Okay, let's move up the foot to tinea unguium, or onychomycosis, fungal nail infection. This one is notorious for being hard to treat.
A profound challenge. The fungus causes the nail to get discolored, thickened, and it separates from the nail bed. And toenails are affected far more often than fingernails,
Why is that?
partially because of the dark, damp environment inside a shoe, and also because toenails just grow much more slowly. The main culprits are usually Trichophyton rubrum and Trichophytum integraphytes.
And the core issue with treatment here is penetration, right? The nail plate is just hard, dense keratin.
Exactly. Topical treatments really struggle to get enough drug concentration to the actual site of the infection, which is often under the nail. So the consensus in our sources is clear. Oral antifungal therapy is far more effective.
But this requires a huge amount of patience.
Immense patience, because you essentially have to wait for a completely new uninfected nail to grow from the base all the way to the tip, pushing the old infected part out.
How long are we talking?
For terbinafine, treatment is 6 weeks for fingernails, but it extends to 12 weeks for toenails,
3 months.
3 months. And if you use an older drug, like grisefoldin, the duration can be up to a year for toenails. Think about asking a patient to take a potent drug every single day for 12 months. Compliance is a major hurdle.
Yeah, no kidding. Okay, let's shift to Taeta capitis ringworm of the scalp and hair. This is a big one in kids.
It is, yeah. Primarily affects school-aged children between 3 and 10. It's an infection of the scalp, the hair follicles, and the skin right next to them. Teton trans is a really common cause.
And how does it present? What does it look like?
Most often you see dry scaling and maybe a gray patch. The more distinctive look is something called black dots, which are actually hairs that have been so invaded by the fungus that they break off right at the scalp surface.
And then there's the most severe presentation, the chirion. That sounds pretty alarming.
A chirion is a deeply boggy, inflamed, pus-filled lump. And if this intense inflammatory reaction is left untreated, it carries a really high risk of permanent scarring and permanent hair loss in that area.
And here's the crucial clinical point, right? Because the infection is deep in the hair follicle.
Topical treatments alone simply cannot work. They can't get deep enough. Tinea capitis requires oral therapy. No exceptions.
So the treatment logic is all about the depth of penetration needed. What's the first-line oral treatment for kids?
Grisefoldin is the standard first line. It's dosed by weight, usually for about 8 to 10 weeks, and it's critical that it's taken with a fatty meal to improve its absorption.
What about adjunctive care? Things to do besides taking the pill?
Absolutely. Daily shampooing with an antifungal shampoo helps physically remove the infected scales. And because it's so contagious, family members who culture positive, even if they don't have symptoms, should also use an antifungal shampoo to break that cycle of reinfection.
Okay, let's quickly run through the other tinea types. Tinea corporis body ringworm.
This is basically any ringworm infection that's not on the feet, groin, face, or hands. You get it from direct contact, human or animal. Treatment is usually straightforward topical antifungals. For extensive cases, you might use a short course of oral terbinafine for a week or two.
And tinea cruris, jock itch.
Infection of the upper thighs and buttocks, it's often recurrent because of the warm, moist environment. Topical therapy is the standard. And here's a good clinical tip. You should continue the therapy for 1 to 2 weeks after the symptoms are gone.
To make sure you fully eradicated it.
Exactly, to prevent that immediate recurrence.
Okay, one last one in this group. Tinea versicolor. This one looks very different from ringworm.
It does. It's caused by Malassezia species, which is actually a commensal yeast that normally lives on our skin.
So, like Candida, it's an overgrowth of something that's already there.
Precisely. It presents as these hyper and hypopigmented scaly patches, usually on the trunk or upper arms. The color changes are subtle. You often only notice them if the person has a tan.
And treatment is usually topical.
Usually. Ketoconazole shampoo is a common one. You lather it on, leave it for a few minutes, then rinse. Systemic therapy, usually itraconazole, is reserved for really widespread disease.
Now, here is that crucial nugget from the sources, the one clinical pearl about tinea versicolor that's a major differentiator.
Yes.
Oral terbinafine is not effective for this condition. Why?
That specific failure point is fascinating. It tells you a lot about the unique biochemistry of the Malassezia organism.
How so?
Terbinafine works by targeting an enzyme called squalene epoxidase in the pathway that makes ergosterol. For whatever reason, maybe it's difference in drug uptake, maybe a metabolic difference in Malassezia terbinafine just doesn't work here.
So you're forced to use azoles or topicals instead.
You are. It's a classic example of how fungal species specificity dictates your drug choice.
All right, let's pivot to the pharmacology. This is where we get into the heavy-duty treatments, especially for systemic disease.
And fighting fungi with drugs is inherently challenging
Why is that?
because their cells are eukaryotic, just like our cells. They're much more closely related to us than bacteria are.
So it's hard to find a drug that kills the fungus without also harming the host. There's a lot of potential for collateral damage.
A huge amount.
Yeah.
And that's why the mechanism of action for every effective antifungal is hyper-focused on exploiting the absolute minimal number of biochemical differences between their cells and ours.
And the primary target, the one that governs almost all of modern antifungal therapy, is
Ergosterol. It's a component of the fungal cell membrane.
the fungal equivalent of cholesterol in our cells.
Exactly. That's the main target.
Okay, so let's start with the real heavy hitters, the polyenes. We're talking about amphotericin B and nystatin.
We have to begin with amphotericin B, AmphoB. It's the standard bearer, the fire hose approach for serious, life-threatening systemic fungal infections. It's been around since 1955.
And for a long time, it had that nickname, amphoterrible.
Amphoterrible, yes. That nickname perfectly captures the historical dilemma. It is life-saving, but it is profoundly toxic.
So let's unpack that mechanism of action. You called it a brute force approach.
It really is. It's a direct, physical attack on the fungal cell membrane. AmphoB binds specifically to ergosterol.
The unique fungal lipid we just mentioned.
Right. It latches onto the ergosterol, and that binding literally creates pores or channels in the cell membrane. It's like it's spiking the membrane with holes.
And those pores compromise the cell instantly.
Catastrophically. The pores allow critical intracellular contents, especially potassium ions, to just leak out, and that leads directly to fungal cell death.
And that's why it has such a broad spectrum of activity.
Extraordinarily broad. It's active against almost all the clinically relevant molds and yeast, Candida, Aspergillus, Cryptococcus, the really tough-to-treat zygomycetes like Mucor. It hits almost everything.
So, highly effective, but that binding isn't perfectly selective. And that's where the toxicity comes from. The traditional formulation, amphotericin B deoxycholate, is, well, it's rough.
It is.
Right.
It's reserved for life-threatening infections, and it requires significant supportive care.
Yeah.
The main side effect is nephrotoxicity,
Kidney damage.
severe kidney damage. Patients often need tons of IV fluids, aggressive potassium replacement, because the drug can cause some leakage in human kidney cells too.
And this massive limiting toxicity is what spurred the innovation that led to the lipid formulations.
The amphotericin B lipid complex, it's a brilliant piece of drug engineering. The drug is essentially encapsulated within a little lipid carrier.
And what does that do?
That carrier is designed to distribute the drug into tissues more rapidly. You get less free drug floating around in the bloodstream where it can damage the kidneys.
So it's a targeted delivery system.
In a way, yes. The brilliant part is that the drug gets disproportionately delivered to the immune cells and the organs where those cells congregate.
So where does it end up achieving the highest concentrations?
The highest levels are in the spleen, the liver, and critically, the lungs.
The lungs, the primary portal of entry for molds like Aspergillus.
It's a massive clinical advantage.
Yeah.
And you get significantly lower levels in the kidneys.
Which is the whole point, a dramatically reduced rate of nephrotoxicity.
Exactly. And it also reduces those painful infusion-related reactions like fever and chills. This safer profile is why you can use a much higher dose of the lipid complex 5 mg/kg daily compared to the old formulation.
Okay, let's move on to the next massive class of antifungals.
The azoles.
The azoles. They approach the problem from a totally different angle. They don't poke holes in the membrane, they prevent the fungus from building it correctly in the first place. An elegant, indirect approach.
It is. The core MOA for all azoles is the reduction of ergosterol synthesis. They do this by inhibiting a key enzyme in that biosynthesis pathway.
A fungal cytochrome P450 enzyme.
Right. Think of the fungal cell as a factory, and ergosterol is the specialized brick it needs for its membrane. The CYP-P450 enzyme is the foreman on the assembly line that makes that brick.
And the azole drug comes in and just shuts that assembly line down.
Puts a stop sign right in front of it. The cell can't make proper ergosterol, so the membrane becomes leaky and dysfunctional, and the fungus either dies or stops reproducing.
And we can break the azoles down into two subgroups based on their chemistry, the imidazoles and the triazoles.
Right. It's based on the number of nitrogen atoms in their chemical structure. The imidazoles have two. They're the older generation, ketoconazole, meconazole, clotrimazole.
And they were less selective, right? They caused more side effects.
They did. They tended to affect our own mammalian sterol synthesis more because our P450 enzymes are pretty similar to the fungal ones. That's why they cause more endocrine side effects.
Then you have the more modern, refined versions, the creazoles. 3 nitrogen atoms. This includes fluconazole, itraconazole, and others.
The triazoles are generally much more targeted to the fungal enzyme. They have less effect on our own sterol synthesis, fewer endocrine side effects, and they tend to have a longer elimination time, which allows for more convenient dosing.
Okay, let's focus on a couple of key specifics. Fluconazole is a real workhorse for many candida infections, but the major clinical hurdle is renal management.
It requires significant renal adjustment. This is a key responsibility for any clinician using it.
What does that mean in practice?
It means you have to adjust the dose based on the patient's kidney function, which we measure with something called creatinine clearance, or CRCL.
Because the drug is cleared by the kidney?
Primarily, yes. So if kidney function is impaired, the CRCL is less than 50 milliliter, the drug will accumulate to toxic levels. So you have to cut the dose, usually by 50%.
And we also have to worry about drug interactions.
A recurring theme for the azoles. Fluconazole is a moderate inhibitor of an enzyme called CYP2C9. This is critical for patients on drugs with narrow therapeutic windows, like the blood thinner warfarin or the anti-epileptic drug phenytoin.
So if fluconazole inhibits the enzyme that normally clears warfarin,
warfarin levels will shoot up, and you get a dangerously increased risk of bleeding.
Now, itraconazole has an even more intensive profile when it comes to this stuff.
It does. Itraconazole is both a major substrate of and a strong inhibitor of CYP3A4.
Which means
there are an enormous number of potential drug interactions that have to be managed meticulously. But the critical safety point, the one that makes doctors pause, is the absolute contraindication related to cardiac health.
This is the deal breaker.
It is. Itraconazole is absolutely contraindicated in patients with congestive heart failure, or CHF.
And the reason is its negative inotropic effects. Let's define that. What does that mean for the heart?
Inotropy relates to the force of muscle contraction. A negative inotropic effect means the drug weakens the force of the heart muscle's contraction.
So in a patient who already has a weak heart from CHF, this drug weakens the pump even further.
Which can precipitate acute heart failure or drastically worsen their condition. It's a huge risk. And it proves that even these refined triazoles, while more selective, still interact enough with human biochemistry to carry major risks.
Okay, let's move beyond the azoles and polyenes. There's a newer class of antifungals, the echinocandins.
Yes, like caspofungin. And they have a radically different and, you could argue, a much safer mechanism of action.
Why is that?
Because they target a structure that human cells simply do not possess. They are beta-3-dodecyl glucan synthase inhibitors.
Okay, what is glucan?
Glucan is the main sugar component that provides the structural rigidity for the fungal cell wall. Human cells have membranes, but we don't have cell walls.
So by inhibiting the enzyme that builds that wall,
You compromise the entire structural integrity of the cell, and it basically collapses. It's a highly selective target.
and what's it used for?
Caspofungin is highly effective against Aspergillus and many Candida species, including some that are resistant to azoles. It's often used for invasive aspergillosis in patients who have failed or can't tolerate Ampho-B or voriconazole.
A key practical point about administration.
They have no oral absorption. They must be given intravenously.
Okay, next, the elamines, which includes terbinafine. This is the powerhouse oral drug for many of those skin and nail infections we talked about earlier.
Right. And its MOA is distinct from the azoles, but it still targets ergosterol synthesis. It inhibits an enzyme called fungal squalene epoxidase, which blocks an earlier step in the pathway.
And the major clinical advantage of terbinafine is its pharmacokinetics, where it ends up in the body.
It's highly lipophilic. It loves fat. So the drug accumulates heavily and persistently in the skin, the nails, and in fat tissue.
And that's why it's so good for dermatophytes.
That's precisely why. It's also why you can treat athlete's foot with just a 2-week course. The drug stays concentrated in the skin for weeks, even months after you stop taking it.
Finally, let's touch on grisefolvin, an older agent with a really unique mechanism.
Grisefolvin is interesting. It's fungistatic, so it just stops growth rather than killing the fungus, and it only works against dermatophytes.
And its unique trait is that it gets deposited in keratin precursor cells.
Exactly. It integrates itself into the very structure the fungus is trying to eat. It gets built into the new, healthy hair and nails as they grow.
Which is why the treatment duration is so incredibly long.
Extraordinarily long. 6 to 9 months for fingernails, and at least a year for toenails.
And what are the main concerns with such a long course of therapy?
Beyond compliance, there are significant monitoring requirements. Hepatotoxicity is a concern, but also hematological issues like leukopenia-low white blood cells. You need weekly blood checks for the first month.
And a really important drug interaction for women.
Absolutely critical. Grisefolvin is a potent enzyme inducer. It revs up the metabolism of other drugs. Most importantly, it reduces the efficacy of low-estrogen oral contraceptives.
Meaning the patient needs an alternative form of contraception for that whole year of treatment and for a while after.
Yes. It really shows how managing even these superficial infections involves some pretty high-stakes systemic pharmacology.
It really does. It's a delicate, powerful balance.
Well, we've covered a lot of ground today. We've navigated the vastness of the fungal kingdom, from the basic difference between opportunistic yeasts and environmental molds,
To the clinical manifestations of all those tinea infections, understanding why the depth of the infection dictates the entire treatment strategy.
And we finish by breaking down that pharmacological strategy, which is really a story of targeting ergosterol.
You have the drugs that kill by brute force, like amphotericin B punching holes in the membrane, versus the drugs that kill by attrition, like the azoles blocking its synthesis.
And what really stands out, and which should be your key takeaway, is that precise targeting. Antifungal drugs succeed because they focus on ergosterol, a sterol unique to the fungal cell, instead of the cholesterol in our human cells. That biochemical selectivity is the cornerstone of the whole field.
And here's where it gets really interesting, though, because it connects right back to that high-risk, immunocompromised patient population we started with. Despite that elegant biochemical selectivity, our sources show us that these drugs are still far from perfect. The clinical profile of so many of these antifungals, from Ampho-B's kidney toxicity to itraconizole's effect on the heart, it all demonstrates significant, unavoidable collateral damage.
And this raises a really important question for you, the learner, to consider as you wrap this all up. Systemic fungal infections are overwhelmingly a disease of the immunocompromised.
Right.
And as modern medicine gets better and better at extending life in those populations through better cancer treatments, more organ transplants, complex critical care, the prevalence of these opportunistic mycoses is only going to increase.
So the drugs we have are powerful, but the biochemical trade-offs are significant. What does this chronic toxicity tell us about the future? About the necessity for even more precise, less toxic pharmacological innovations? The next frontier in infectious disease might just be designing a drug that can completely stop a mold like Aspergillus without ever touching a human kidney or weakening a failing heart.
Something to mull over as you digest all this knowledge.
We appreciate you joining us for the deep dive.